feel you?
Hello, hi, how are you, sir?
Okay, I'm going to start. Tumbi?
Yeah.
Go ahead.
Good evening, everyone. There is happiness in life to love and be loved. Happy Valentine's Day, everyone. Ladies and gentlemen, welcome all of you to World Malayalee Council New Jersey All Women Province proudly presents a seminar on COVID-19 impact in adults and children, vaccines, and health disparities. On behalf of WMC, I would like to extend my warm welcome to all the great speakers to this health forum discussion. Our keynote speakers of today's session are Dr. Anuj Mehta, Dr. Nisha Nigel, Dr. Elizabeth Maman Prasad, Dr. Kripa Nambiar, Dr. Joshua P. Prasad. Welcome, all of you. Now, I would like to invite Global President Gopala Pillai, Vice President P.C. Matthew, America Region Chair Philip Thomas, President Sudhir Nambiar, General Secretary Pinto Kannambali, Treasurer Susil Cherian, New Jersey All Women's Province members, All Global America Chair, Province Chair, Honorable Speakers, welcome everyone. On this occasion, I would like to invite New Jersey All Women Province President Malvi Nair to talk about this report. Welcome, Malvi Nair.
Thank you, Tumpi. Hi, everyone. Welcome to this first health forum from the New Jersey All Women Province of New Jersey. Wishing you all a very happy Valentine's Day. And it's my pleasure to welcome you all to this informative forum on COVID vaccines and the related topics. It's my pleasure and privilege to welcome our New Jersey All Women Province Healthcare Chair, Dr. Kripa Nambiar. Dr. Nambiar has been a practicing physician in the primary care since 2004. Kripa graduated from Calicut Medical College in Kerala and did her residency in Stony Brook University in Long Island, New York. She was also the recipient of the Best Resident Award. For the past 16 years, Dr. Nambiar has been working as a community physician and hospitalist for Robert Wood University Hospital and St. Peter's in New Brunswick, New Jersey. Dr. Kripa will be talking about COVID-19 vaccines in the outpatient and nursing home facilities. Again, welcoming Dr. Kripa Nambiar to this forum.
Thank you, Malini, for that kind introduction. Good evening, all. Let me share my screen.
You're seen, Kripa.
Sorry. It's hard to believe that more than a year has went by since the world has been under lockdown under the gripes of this novel mRNA COVID-19 vaccine. We have come a long way in understanding this disease, but there's much more to be unveiled. Here, let's talk about what we know. I'm sorry.
Your slide is not forwarding.
Yes. So I would like to say that sometimes I say that the most common symptom of COVID-19 is denial, because most of the time the symptoms are so non-specific and unassuming, the symptoms being fever, cough, shortness of breath, loss of taste or smell, less commonly seen pharyngitis, headache, productive cough, nausea, vomiting, diarrhea, coughing up blood, chest pain, confusion, skin changes, and skin changes basically known as comatose. The National Institute of Health has categorized COVID-19 symptoms into mild, moderate, severe, and critical. The mild and moderate symptoms could be managed in an ambulatory setting. The transmission, primary mode of transmission is through respiratory droplets. That's why masks are recommended to reduce spread. Aerosolization is possible from speaking or singing, and there is evidence that small droplets could infect others even at an increased distance, hence the recommendation for physical distancing. Viral shedding can predate symptoms, and viral titers are at highest at least 1 to 2 days before the onset of symptoms. So asymptomatic individuals are major contributors of viral spreading, which makes this disease even more frustrating to contain. The COVID-19 disease course, talking about that, the incubation period is 2 to 5 days. Infectious period, where someone can transmit the disease to others, can start anywhere from 2 days prior to appearance of symptoms and last for at least 10 days. Symptomatic period usually is 2 to 4 days after exposure, most of the symptoms are happening around day 5. If the illness becomes severe and unfortunately the patient dies, the time from the first symptom onset to the time of death could be around anywhere from 9 to 25 days. How do we diagnose this disease? There is serological testing, where we detect IgM and IgG antibodies. And IgM antibodies can appear in patients infected with COVID-19 virus around 5 to 14 days. It's not a diagnostic test, and it can cross-react with other coronavirus. Antigen test, where we detect viral proteins in nasal cavity, done at point of care. It takes less than 15 minutes, but it's less sensitive. The gold standard is actually the real-time PCR test that detects viral RNA and DNA. It cannot distinguish between live and dead virus. So hence you get to see these people who have recovered from COVID-19 virus still testing positive for weeks together. Quarantine. We have to stay at home for 14 days after last contact with the person who has been infected with COVID-19. Nowadays, public health departments are allowing a 10-day quarantine or a 7-day quarantine, even with a negative test that happens after 5 days. Monitoring for fever, cough, shortness of breath, or other COVID-19 symptoms are very important. And making sure you stay away from people who can get very sick from COVID-19 is actually equally important. How do we manage patients at home? It's basically mostly supportive care, hydration, rest, fever control with ibuprofen and acetaminophen, making sure that taking vitamin D, vitamin C, zinc, although there's insufficient data to see how they kind of like reduce the severity of illness. Antibiotics and anti-inflammatory agents like Decadron does not have much role in outpatient setting, nor do anticoagulants or antiplatelet therapy, unless there is clinically indication. Pulse oximeter, which detects oxygen level in blood, can be used if used appropriately. Now, the use of monoclonal antibodies for reducing the risk of infection, hospitalization, or even death have been identified in certain class of patients. And who are these class of patients? They are anyone above the age of 65, people who are 55 with one or more comorbid conditions, which could be hypertension, asthma, COPD, chronic kidney disease, obesity, the BMI being more than 35. It could be non-insulin dependent diabetes mellitus, immunosuppressed state, be it from cancer or HIV, and cardiovascular disease. Now, the two options available approved by FDA are bamlanivimab and a combination of casirivimab and imdimimab, which is it's given as an infusion over 1 hour period in select outpatient infusion centers and ER settings upon the request of requesting provider. It can also be given to children between the ages of 12 and 17 and above the weight of 40 kilos, as long as they have coexisting conditions like congenital or acquired heart defects, sickle cell anemia, neurodevelopmental delays like cerebral palsy. Now, it has to be noted that this monoclonal antibodies should have to be administered before the 10 days within 10 days of onset of symptoms. And normally patients do well with this treatment and don't have general allergic reactions. How do we to prevent the spread of this disease? Is mostly by staying at home and making sure that the patient do not leave home except to get medical care. We do recommend rest, hydration, and symptom management. It's very important to monitor symptoms and encourage the patients to call their primary care provider if there's any change in their symptoms. Infection control at home can be achieved by making sure that the patient stay in one specific room and away from other people and pets. Also making sure that if they do share bathrooms, disinfect after each use, encourage masks use if patient has to be around other people, and also making sure that high contact areas, high touch surfaces are disinfected appropriately. Now, when do we escalate care, or what are the trigger factors to send patients to the hospital? It all depends upon trouble breathing, increased trouble breathing, chest pain, increased new onset of confusion, inability to wake patients up, the pulse ox consistently being below 93% of room air, and bluish lips or face. Now, the groups that are at increased risk that can end up in hospitals would be anyone above the age of 65 and those with comorbid conditions. The ones with definite risk including cancer, chronic kidney disease, COPD, immunocompromised state from organ transplant, obesity, serious coronary vascular disease, sickle cell disease, type 2 diabetes, pregnancy are all belong to this category where they can end up in hospital. It has to be noted that persons of color are disproportionately affected with this disease. Now, since we've been dealing with disease over the past 1 year, we have seen this phenomenon called long COVID. About 90% of non-hospitalized patients fully recover by day 21. But the rest of the patients could have protracted or persisting symptoms, which can linger on for 3 months or even longer. And they are clubbed together as long COVID. And these symptoms could vary from cough, fatigue, chest tightness, cognitive blunting or brain fog, anxiety or depression, skin rash, or even diarrhea. Management basically includes emotional support, ongoing monitoring, symptomatic treatment, and then making sure comorbid conditions are treated. A quick look at nursing home and COVID-19. Now that the US is approaching almost 500,000 cases, it is fair to say that the major brunt has been on nursing home patients, rightfully so, because they harbor elderly population with multiple comorbid factors. And the symptoms escalating rather quickly in older patients does not make the situation easier. Plus the fact that most of these patients have dementia, which makes reporting even more harder. Now, how do we manage patients in nursing homes? Basically supportive care, hydration, keeping up with hydration, where sometimes we might have to resort to intravenous fluids, using anti-inflammatory agents like decadrone or colchicine, antibiotics in appropriate settings, supplemental oxygen. And yes, we do transfer these patients to hospitals for monoclonal antibody therapy as well. The general measures taken to reduce infection is making sure that visitors are restricted. And we make sure that daily symptoms screening is done. Trying to separate patients who have been affected with COVID from non-COVID patients also helps. Periodic testing of residents and healthcare provider, either once a week or once in 2 weeks, is also recommended. Trying to minimize hospital transfer for management of chronic conditions, as well as making sure that you discuss with family members about advanced care planning in case they end up having this deadly virus. And the key to reduce infection and limit the spread is absolutely one, vaccination, which my fellow panelists are going to touch upon. And with that said, I'm going to invite Dr. Nigel, the second speaker in this panelist, to discuss about COVID-19 vaccine updates. Now, Dr. Nisha Nigel is an internist and endocrinologist. She's working at as an assistant professor and staff physician at Northern Ontario School of Medicine. Dr. Nisha has keen interest in knowledge translation and has won the prestigious PSI Graham Knowledge Translation Award. She has advanced training in clinical epidemiology from University of Toronto, and her research is based on metabolic bone disease and thyroid nodules. She has won several awards, and including Young Investigator Award from the Endocrine Society in USA. It's a great pleasure and honor to have Dr. Nisha Nigel amongst us today to give a presentation on COVID-19 vaccine update and mutant strains, COVID-19 in diabetes, and COVID-19 vaccine in pregnant ladies. Thank you all.
Thank you. Thank you, Dr. Nambiar, for that wonderful overview of the primary care aspects of COVID-19 pandemic. Am I audible?
Yes.
Thank you very much. So I will be briefly covering the impact of the current vaccination regimen and mutant strains, the interactions especially, and vaccine coverage in special populations, for example, pregnancy, cancer patients, immunosuppressed patients. So most of what is being mentioned here is adapted or the reference to the following organizations. So currently we are looking at nearly 100 million total cases and 2.4 million deaths worldwide. Interestingly, 170 million people have been vaccinated. US is heading the number of vaccinations with more than 40 million people vaccinated already. And new daily vaccinations ranged from 5.5 to 6 million, which is very encouraging. So this is the New York Times coronavirus tracker. We see 4 vaccines for various reasons have been abandoned, and we have 4 vaccines approved for clinical use. And these are the basic concepts around the Moderna and Pfizer vaccines. I'm not going into the details because most of us are very familiar, and we all know that the vaccine efficacy is around 95%. The dosing is twice. And I think many of you may have already received the vaccine, so I'm not going into the details. And one of the big questions that always come up is that how long do the antibodies last? So far, based on trials, the antibodies have been shown to last 6 to 8 months. But mind you, there's also a T cell component to it, which might give us prolonged immunity. We still don't know how durable and how protective that T cell response is. Yes, they do evoke a good T cell memory response. And it takes up to 14 days to mount a good vaccine response. And the second dose is very, very important to provide that activation of our T cells and B cells. So we need 2 doses. Now, we do know that in the clinical trial setting, we have seen that the vaccines have up to 95% efficacy, but that's a controlled setting, right? We do want to know whether these vaccines have similar efficacy in a real world. And even before the vaccine rollout began, we were told that the vaccines prevented severe disease. If you look at this part of the curve here, yes, they are known to prevent severe disease. So that's where we are looking at reduction in number of hospitalizations and in the number of people dying from COVID vaccines. Imagine if we had these vaccines available in March or April, even in the United States, we would not have hit this number of 500,000 deaths. So that's a hard outcome we are looking at. And if you look at the total vaccination, the world is really looking, and we're really awaiting data coming out of Israel, because Israel has vaccinated the maximum number of people per 100 residents. So if you look at the overall number, they have vaccinated 68 doses given per 100 residents. The total million given is 6.2. Similarly, UAE and United Kingdom have done 21.8, 40, and 65 respectively. So if you look at the US numbers, we have 46 billion people vaccinated. Chinese population, 40 million have already been vaccinated. In the UK, 14 million. And India is also leading with 7.5 million vaccinations. So in US total, the daily average vaccinations is around 1.6 million. So they are expecting this number to be doubled so that we can complete the vaccinations way ahead of our timeline. Now, this is the efficacy showing that the vaccines do prevent severe disease and mortality. This is the clinical trial data on AstraZeneca vaccine, which is the Oxford vaccine, which is being widely used in India. Now, this data is adopted from The Economist, showing that the vaccine efficacy is somewhat matching what we saw in the clinical trial data. This is data coming out of Israel, showing that the number of hospitalizations have come down significantly in the age 60 plus subgroup. But interestingly, there is also a slight increase in the COVID-19 cases in the younger age groups. All the more reason that we have to alert our younger folks to stay vigilant and follow public health guidelines. They are still vulnerable. But in the real world, the vaccine efficacy is very, very promising. So out of 500,000 fully vaccinated, that means 2 doses requiring, this is one particular cohort they observed, and out of 500,000 in that cohort, only 540 people got infected. So the infection rate is very, very less, and only 4 had severe disease and no death. So 94% efficacy, which is kind of reflective of what we saw in the clinical trials. So this is very, very promising. And this is the herd immunity threshold projected for US, around 70% based on the herd immunity, the vaccine threshold, but it might be different as we see more variants coming out. Now, coming to the variants, so in the media, you see that these names are being used interchangeably. Some say variants, some use strain, some say it's a lineage, but they're all different based on mutations. So the mutation is an actual genetic change happening within the virus. And then when specific mutations happen, and sometimes with a minor change in the virus genetic makeup, we call it a variant. But if the variant is actually causing a lot of disease modification in the community, then we call it a strain. Okay, so that's how these names have been derived. The concern is, are these new variants more readily transmitted, or are they more virulent? Are they causing severe disease, or in contrast to the wild strain, or are they evading the vaccine response? So those are the emerging concerns, and these are the genetic makeup of these variants. So I'll not go into the details. And in UK, the most prevalent variant now is B117. And interestingly, this UK variant has evolved in more than 70 countries. And in the South African variant is now called B1351. Actually, we're not, in the scientific world, we are only allowed to use these variants by the number, but for simplicity's sake, I'll still have to use the names, okay? So these are the different types of variants, and again, I covered this. So, and there's last week update on emergence of a new variant in Southern California as well. This is preliminary report. Again, new vaccines such as Janssen is trying to analyze efficacy of these vaccines in these variants, and they have found that in the Brazil, there is some amount of efficacy against these variants as well, which is very, very encouraging. Janssen and Novavax reported their trial data first, so we do know that these vaccines do work, not with 90% efficacy, but good amount of efficacy against the other variants as well. So that is promising and very optimistic. Now, B117 variant is a UK variant, and it is now widely circulating in the US, and especially in North America as well. In Canada, in a remote province, we had an outbreak yesterday. They didn't have any cases until recently. So they had a 200% outbreak just last week with this UK variant. So it is conquering the North American continent. Now, this is a summary slide of how the variants are behaving in the community. Of course, with the UK variant, there is increased transmission, and the vaccine efficacy, again, not much concern as far as the UK variant. We do now have data showing that the Pfizer and the Moderna vaccine do have good efficacy against the UK variant, which is circulating in the US. So people who have been vaccinated with the Pfizer or Moderna vaccine can be reassured that you do get continued protection. And as far as the South African variant is concerned, yes, there is some reduction in vaccine efficacy, but they do work. And all of these vaccines prevent severe disease, which is very encouraging. Now, Pfizer vaccine, this is the experimental study that I was mentioning. This was a small experiment they did in 20 participants, and they showed that there is efficacy against the UK variant, which is encouraging. And this is data coming out of the Moderna vaccine showing scientific evidence that there are antibodies that can be neutralized. And Novavax and Astra vaccines have shown efficacy against the South African variants. And so far, these three vaccines have shown efficacy. Other trials are ongoing, so we can be reassured that there are some benefits on preventing hospitalization and that these are the hard outcomes. So again, promising. And this is a summary slide. I think I've covered all the topics so far, and we will get more published data on Moderna and Pfizer. The data I showed was preprint data. We are waiting for the original publication. So that is about the variants. And this is the summary slide. So if you look at the Novavax again, there is good amount of efficacy against the UK variant, 60% efficacy against the South African variant, and 89% efficacy against the wild strain. And again, Pfizer, these trials are pending, and Moderna trials is already showing 94% efficacy against the UK variant. So overall data appears optimistic. Now I'm going to skip the slides in the interest of time. And this is another study. This was published last week, again, looking at the T-cell response to these vaccines against the UK variant and also the South African variant. And again, there is a promising T-cell response, not just antibody response, also potentially T-cell response against the variants. And this is done on Pfizer vaccine. So again, encouraging data here. So although the neutralizing antibody levels might be reduced, we also have to depend on the T-cell mediated immunity, which for now is looking promising. Now, again, the other important aspect is vaccine hesitancy. We are starting to hear a lot of young people rejecting, and they say they are not at risk, and COVID-19 is not that bad in young population. But I briefly mentioned data coming out of Israel. Yes, we are starting to see more younger folks starting to get affected, and we don't know how the B.1.1.7 variant is going to evolve. We might see more people getting affected, and also the long COVID, as Dr. Nambiar just outlined. And also, there is also potential that the vaccines can prevent in person-to-person spread. So by getting vaccinated, you are preventing your grandparents from getting the infection from you, or you're also preventing other people getting infected from you. And also by getting vaccinated, you are getting good protection against potential variants that might come to your community. So that is the immunity that you get from natural infection is weaker than a vaccine-induced immunity. So your best bet is to get vaccinated because you get strong, durable immune response. This has been proven across many scientific experiments. So vaccine immunity is definitely better than natural virus-induced immunity. Okay, and of course you don't get, even if you get sick, you don't get severe infection if you're vaccinated, and your chances of dying from a COVID infection is very, very minimal if you're vaccinated, okay? So now coming to the special subgroups, children, older people, pregnancy, etc. Pfizer vaccine has only been tested in people who are older than 16, and Moderna has already been tested in people who are older than 18. But children previously were not a priority group because they were not likely to develop severe disease. But now with the B.1.1.7 variant, there is a concern that children can get more multi-system inflammatory disease. So there is a concern. And also, so that is why we are thinking that children might need to get vaccinated, and having a safe vaccine will help, opening of schools safely. So in the Oxford trial, now they have recruited child volunteers. Pfizer and Moderna are also, Pfizer for sure, have announced plans to recruit children, and we'll have the data by summer. And older people, yes, the vaccines do work. We have seen that hospitalization death in older people are significantly reduced in the Israel population. So we now have evidence from all sources, and interestingly, older people have less side effects from vaccination. And in cancer, again, they are prioritized to get vaccine, although they are immunocompromised. There is speculation that the immune response might be less in cancer patients, especially when they are immunocompromised, but all the cancer societies are now advocating for their patients to get COVID vaccine because the outcomes are bad when they get the disease. So even though, yes, cancer patients have mostly been excluded from trials, but they appear safe, and the continued data surveillance will give us more data. There will be some specific guidelines on a individual case by case basis based on when to time the chemotherapy, etc. But if you look at the overall risk benefit profile, it is beneficial for cancer patients and immunocompromised patients to get vaccinated. Okay. Now, pregnancy and breastfeeding, there was a lot of confusion because in the UK, they said pregnant women were asked not to get vaccinated. In the US, pregnant women were allowed to get vaccinated if they're willing, but now UK guidelines have changed, and with the variant spreading and with more community spread, now the UK guidelines are more relaxed, saying that pregnant women may be offered to get vaccinated. If looking at the risk benefit ratio, again, absolutely no safety concerns in pregnant women. In fact, pregnant women, if they get COVID during later stages of pregnancy, they have bad outcomes and more risk of hospitalization and death. So in the trials, in both Moderna and Pfizer trial, around 20 to 25 people got pregnant. They did not have any bad outcomes. Similarly, in the Oxford trial too, some women got pregnant, and again, no bad outcomes. And then if you look at the overall American data, out of the 10,000, there were 10,000 pregnant people got vaccinated. Again, so far, no bad outcomes have been reported. So that's real world data, which is very, very robust. And again, there's no scientific evidence suggesting that vaccine can cause infertility. This has been dismissed by all scientific organizations, and various scientific studies have been done disproving that false claim. Now, again, there is no concern about lactating mothers getting vaccinated. Again, this vaccine is not transmitted into the mRNA is not present in the milk, so there is no risk for the fetus. In fact, if the mother has good antibodies, it'll be transmitted, so it's actually protective. And again, coming to autoimmune conditions, all the various organizations have come out with specific guidelines. So again, it is not a contraindication. Even people with autoimmune conditions are encouraged to get vaccinated. Again, there is some timing as to when you should stop the methotrexate, or when you should, there's some timing schedule that can be discussed with your primary care provider. Again, there is absolutely no contraindication to get the vaccine because these are safe. These are not live vaccines, so these are absolutely safe. And you're asked to complete this questionnaire when you go through the vaccination schedule. And allergy, again, very, very minimal, 5 per million, or even extremely rare. There was a recent publication looking at the anaphylaxis data. There were no deaths at all, and all the anaphylaxis happened within 10 minutes of getting the vaccine. Extremely rare, so that's also not a concern. And you have to go through all this questionnaire before getting vaccinated, so all the safety precautions are being carried out. And why we should all get vaccinated soon, this is the reason. We are seeing new variants appearing in the North American continent, so sooner we get vaccinated, the better. So the vaccines can prevent the spread and prevent the onset of newer, virulent, stronger variants. So we have a responsibility as a society to get vaccinated. And unfortunately, we are not safe unless everybody else in the world is vaccinated. Sadly, 130 countries in the world are yet to administer a single dose of vaccine as per UNICEF data, and 2.5 billion people are still waiting to enter the vaccine campaign. And now with all the advancements in mRNA technology, we are now seeing that there is a lot of hope towards developing a single dose variant proof vaccine. So there's also a big push in the scientific community towards planning for the next pandemic. So in general, the outlook is optimistic, and I would like to conclude by this slide. Thank you very much for the opportunity.
Thank you, Dr. Nisha. Thanks for your informative session. Now, I would like to invite Dr. Elizabeth Maman Prasad. Before that, I just wanted to talk some words about her. Dr. Elizabeth Maman Prasad is an infectious disease physician practicing in New Jersey for past 30 years in private and faculty practice. She completed her fellowship in infectious disease at Newark Birth Israel in 1992. She completed her residency in 1988 from Detroit, Michigan Medical School from AUC. In 1984, Bachelor's of Science from Texas Tech in 1981. Dr. Maman Prasad has held numerous leadership positions, such as President of Medical Staff of EOGH, Chief of Infectious Disease, Chair of Infectious Prevention Committees, Bylaws Committee member, to name a few. She also mentors high school students interested in pursuing field of medicine. Her interest are in infections and tick-borne illness, to name a few. Dr. Maman Prasad enjoys community service through educational programs and volunteers her name in various social programs. I now introduce Dr. Maman Prasad, who will talk about COVID-19 in children, a newly described condition called MISC, vaccine update in children and general infection prevention practice. Welcome, Dr. Maman Prasad.
Thank you, Tumbi, for that nice introduction. So if somebody can load my slides. Okay, my objective for today is basically a lot of our panelists have discussed majority of the vaccine issues and the settings in primary care setting, as well as the elderly. But I'm going to talk about children as we are starting to see more cases in children. So COVID-19 presentation in children and young adults. What is MISC or MIS? Vaccine for children and young adults, where are we in terms of that, and prevention? So can kids catch coronavirus? What we know about COVID-19 and children. Next slide, please. So that is the aim of our talk for today, and explaining to parents how we handle a child that comes down with COVID and what happens when they go to the hospital. Next slide, please. COVID-19 in children, does it happen? So initially during the pandemic in the US, globally, fewer cases were reported in children compared to adults. That has changed over the past several months. Children comprise of about 22% of the US population, and the ages are 1 to 17 years of age. The actual incidence of COVID in children is still unknown due to lack of widespread testing. Recent evidence suggests children can spread to others similar to adults. Due to community public health measures, school closures during early part of the pandemic in the spring and summer of 2020 helped reduce the incidence of spread in pediatric population. What are the signs and symptoms in children and young adults? The incubation period, as we just discussed by the other panelists, is roughly 2 to 14 days. Majority of the children are asymptomatic or may have mild disease or mild illness. Majority of the children will recover on their own. Most common symptoms that the children tend to have are cough and fever. Some may have tiredness, headaches, body aches, coughing, runny nose, nasal congestion, loss of smell or taste, if they're able to say those things, or sore throat. Some children may have difficulty breathing, stomach pain, diarrhea, nausea and vomiting, poor appetite, or poor feeding. Some children with severe or serious medical conditions can develop conditions associated with COVID-19, which we call MIS-C. So children may be happy, as you see on the left side, or they may come down with this rash, and the rashes are in many forms in a child. Or, next slide, the only indication that a child has coronavirus or was or exposed to was maybe this rash you see on the toes, we call COVID toes. Next slide, please. Children with certain conditions have risk for severe COVID-19. They are asthma or chronic lung disease, diabetes, genetic, neurological, or metabolic conditions, sickle cell disease, heart disease from birth, immunosuppression or weakened immune system, whether it's from chemotherapy or steroids, obesity. Also, certain ethnic populations, such as the Hispanic, African American, have a higher risk. Adolescents, young adults who smoke or vape results in decreased lung capacity, puts them at risk for progression of their COVID illness. Drug abuse obviously weakens your immune system, again, puts them at risk for coming down with COVID in these high-risk situations. So MISC, there's so many different ways to say this term, but it's actually multi-system inflammatory syndrome in the US. And of course, CDC is tracking these cases. So we think it is associated with COVID-19. As of January 28, 2021, 2.8 million children has been tested positive for COVID since the onset of the pandemic. Initially, it was felt to be a rare condition, but now cases are on the rise. It can be serious in some situations if not recognized and treated promptly. It occurs after they have recovered from a mild, symptomatic, or an asymptomatic course of COVID-19. It usually occurs about 2 to 6 weeks after the initial infection with COVID, with signs and symptoms that cause inflammation of the heart, lungs, kidneys, brain, skin, and so it's a multi-organ inflammation. Next slide. The MISC, as of February 5th, 2021, CDC reports about 2,000 cases of MIS-C in 47 states of the United States, 30 deaths and counting. 70% of the age affected were in the 1 to 17 years of age, median age of 8 years of age. However, there is a MIS-A, which I will not go into. It's associated with multi-system systemic inflammation in adults or young adults. What are the warning signs to seek medical attention? We get a lot of questions from parents asking, when should I take my child and what are the things I should be concerned about? So whether it's parents or grandparents or uncles or aunts who are babysitting their nieces and nephews or their grandkids, they need to watch out for persistent high fever over 101, pain or pressure in the chest that doesn't go away, especially if a child is able to express that, change in mental status, hard to wake up, irritable, rashes on the body, face, and limbs, decreased oral intake, coughing that's becoming more progressive or becoming shorter breath, red eyes, redness of the lips, chapped lips, swelling of the hands and feet. And I'll show you some pictures to describe that. So on the next slide, please. So on the far right, you see a pink eye. That's what commonly seen with inflammation of the eyes. You can have all variety of rashes. Hands are swollen. They can have rashes on their hands. They have chapped lips, very, very red lips. But despite if they may be African-American or Hispanic or white, the intense redness of the lips, you can easily see. And of course, a very miserable child, not able to withstand, a very cranky child, doesn't want to eat anything, doesn't want to drink anything, and a very miserable child. So what is MIS-C and Kawasaki? So parents, are confused when we say the child may have COVID, but we don't know if it is what are the symptoms. And sometimes we have child coming in with Kawasaki syndrome, and sometimes we can't tell them apart. And the parents are usually confused. So how do we clear this up for them? Well, first, MIS-C or MIS-C is associated with COVID-19 post-infection is what we think at this point. Kawasaki syndrome cause we don't know. It causes an inflammation very similar to MIS-C with a negative COVID-19 test and a COVID-19 antibody testing. Most conditions, both conditions have fever for many days, red lips, red eyes and tongue, chapped lips, swelling of the hands and feet, irritable and poor feeding. So how do you tell it apart? And that would be the antibody testing that I just talked about. Kawasaki syndrome, most children are younger in age. And of course, they are also equally at risk for heart problems, especially coronary artery inflammation, as they are at risk for MIs. The treatment is very similar for both conditions, including immunoglobulins as well as anticoagulation. Steroids for MIS-C, less so for Kawasaki. Next slide. What happens when my child goes to the hospital for MIS-C? How do we prepare the parents? First of all, they know that they're going to take a nasal swab, checking for COVID test, along with blood studies, because we know, as I just mentioned, it affects the heart and any major organs of the body. But most important thing that we need to check is the function of the heart. So they'll usually get an echocardiogram done right away. Along with, they may end up getting several echocardiograms during the hospitalization. The treatment will consist with management involving infectious disease specialist, cardiologist, rheumatologist, and hematologist in the pediatric setting. Treatment can involve immunoglobulins, anticoagulant steroids, as I mentioned in the previous slide. Blood work that we look for, such as sedrate, CRP, D-dimers, ferritin, troponin, procalcitonin, fibrinogen, some of the markers we look at and we trend it every day. So it involves a lot of blood work, and parents get very concerned that we are drawing a lot of blood. The goal is to decrease inflammation. So the rheumatologist will decide the duration of the steroids, and the hematologist will decide on the duration of anticoagulation. The ID doctor will decide on the dosaging of immunoglobulins and how many doses we need to give. Usually it's just one. In rare occasions, if we have an active COVID infection, if a child is over 12 years of age, remdesivir has been considered, although I have to use it on a child. So most of the concerns in children in active COVID infection is if they're going to progress on into respiratory distress and ending on a vent, and hopefully that rarely occurs, but it can happen. Post-MC or MIS patients will be followed by the specialist for a while, possibly over 6 months to a year, especially the cardiologist. The children that develop myocarditis or inflammation of the heart muscle, or inflammation of the coronaries, for example, or they have a dysfunction, LV dysfunction, they will have to be followed by cardiologists and have to get clearance from the cardiologist before they can go back to exercising or sports activity. Next slide. Next, I'm going to talk about COVID. Well, Dr. Nisha Nigel explained very nicely of the vaccines, but in children, we don't have any that we're giving out at this point. There are many trials ongoing. So as many of the numbers have been stated, US number of COVID is 27 million cases, deaths 473,000 as per CDC. Now, the COVID-19 vaccines have not been rolled out in children. Many clinical trials are ongoing. We may have a vaccine, hopefully, either later this year or maybe in 2022. The Pfizer vaccine and Moderna vaccine has been discussed already. However, we don't really use it in children at this point because the pediatricians are the ones that usually give them in the outpatient setting, and it's really hasn't been rolled out to them at this point. The total vaccines given so far, about 50 million. That includes first and second dose from some of the data that are reviewed. The common side effects that's been reported has been discussed already. Pain at the injection site, tiredness, headaches, muscle or joint pain, nausea and vomiting, fever and chills. And usually these resolves within 1 to 2 days. The severe allergic reaction or anaphylaxis, as previously discussed, is very rare, but it does occur in rare situations, especially if they're allergic to a couple of components in the vaccine, such as PEG or polysorbate. Next slide, please. So we've already discussed about transmission of COVID-19 and the number of cases and deaths. So majority of the cases we have reported were from respiratory droplets in contact with the respiratory secretions and saliva. Aerosol particles may be another mode. It can be viable on surfaces for hours to days, but the transmission is less through fomites. And of course, there's some data on fecal shedding. What are the mutant strains and does current vaccine? I think Dr. Nisha Nigel really talked very nicely about that. So I'm going to skip that slide and just go on to the next slide. So next slide is by right above it, please. I think you skipped a few. There's a prevention slide, the one after that. Best way to prevent COVID-19.
I believe it's the next slide after where we stopped from.
Okay, right after that.
Then the next one after this.
Yeah, I skipped it.
There you go.
Yeah, so the best way to prevent COVID-19 infection prevention, obviously, wash our hands frequently with soap and water or alcohol base, especially with children. Cover your sneeze and cough. Appropriate age masking, especially over the age of 2. Physical distance outside of your family unit. Avoid crowds. Stay 6 feet apart. Avoid unnecessary travel if possible. And of course, when COVID vaccine, when it becomes available for all age-specific groups. So this is specifically catered for children. So summary slide, children and young adults can be infected with COVID-19. Most are asymptomatic or mild disease. MISC is a condition that occurs after COVID-19 infection, at least as an association, causes inflammation of the various organs. Treatment involves immunoglobulins, steroids, anticoagulation, decrease inflammation, and prevent clots. Parents need to be aware of signs and symptoms of MIS-C and seek the advice of their physician. Vaccines are not yet available for children, possibly end of this year. Follow infection prevention practice, hand hygiene, mask, and keep 6 feet apart, and to stay safe. No handshake. Instead, teach them elbow greet. Thank you. Next slide, please. Did we miss a slide? Next slide, please. Yes, elbow, yeah. And the next slide, please, after that. This is just for medical information only. Please seek the advice of your physician. Thank you. Okay. We're going on to the next speaker. It gives me great pleasure to invite Dr. Anuj Mehta. Dr. Mehta is an MD, MBA, is currently the Chief Medical Officer at Eastern General Hospital since 2018. Dr. Mehta holds the designation of Fellow in Hospital Medicine and has master's degree in Business Administration from Columbia University. He's also a content reviewer for American Journal of Case Reports and Medical Science Monitor. Dr. Mehta has trained and mentored medical students as clinical instructor of internal medicine in Touro College of Medicine. Dr. Mehta comes with various expertise from leadership roles, published articles in various journals, and running a large hospitals program prior to coming to Eastern General as the Chief Medical Officer. It gives me great pleasure to introduce Dr. Anuj Mehta, who will speak about vaccine distribution from a state level, local level, coordinating with Department of Health, vaccine safety and reporting. Welcome, Dr. Anuj Mehta.
Thank you, Dr. Mammon, for that talk as well as the introduction. So, one of the things that we always speak about through this topic, and we've touched upon it, is really prevention of COVID-19, whether we can avoid getting it or we can avoid it by getting the vaccine. And one of the things that we were doing when we were in the peak of it, this is is the chair of our anesthesia department, Dr. Malayalee. And here you see him in what used to be his regular garb when he was seeing patients or intubating patients during COVID-19. So again, I always like to start with this slide because this is very relevant. What are the three main ways of spread of COVID infection? Is either fomites, which is contacts, droplets, which is moist particles, which you expel when you're normally speaking, breathing, or coughing, or aerosols when you're shouting, singing, sneezing. And these are very important spread, mixed mechanism of spread. And we need to focus on the simple things which are inexpensive and are actually very efficacious, which is social distancing, mask wearing, hand sanitizing, sorry. Now, one of the things when you talk about surfaces, and you have to talk about how long does the coronavirus lie on surfaces? So something as simple as, hey, I ordered Amazon packages and they come in a corrugated cardboard. How long do you think if someone had COVID, would it last on that box? Or for a matter, if it's a stainless steel appliance or paper money. What's interesting is the outside of a surgical mask, the virus can actually last up to 7 days, because the virus, with the mask, when it's prolonged usage, gets laden with all the moisture from your mouth from speaking or sweating. And that is an ambient environment for the coronavirus to last in. So whenever you're taking off the mask, try and make sure that you take it off from the ear loops and not touch the front surface of it wherever it's possible. But this is very important. So something like a copper penny, it lasts only for 4 hours. And that's, again, things that you need to know about, especially when you're going out and about. Irrespective of your vaccination status, this is good science to follow. One of the biggest things is avoid face touching. And I think that goes without saying. So let's talk about the current state of affairs. This is as recent as yesterday, actually, from the New York Times. And what you can see over on the right, extreme right-hand side is we started having a peak of cases around January 2021, and it has been trending down. However, this is not the time to say that, oh, the worst is behind us or it can't come back. We continue to see hotspots for virus that keep appearing, whether it's in Texas or California or overseas, where you suddenly have a whole population that starts getting sick again. And then the appearance of virus mutations continues to pose a risk. And this is the reason why in the US, we have had 28 million cases, about 500,000 deaths, or almost 500,000 deaths already. And it's not behind us. It still continues to have about 3,000 to 3,000 deaths roughly on a day-to-day basis. So, minor talk about vaccine development. And, one of the things you have to remember is that this vaccine is safe, it is effective, and it was expeditious. Now, vaccine development, or for that matter, any drug development, is typically divided into 4 phases. Phase 1 and 2 are preclinical phases where you check whether the drug is safe. Is there any serious side effects? Is that dose related to any side effects? Is it causing an immune response? It's all related to safety. The second phase, which has a lot more people involved in it, is to more answer the questions of whether it's efficacious. What are the most likely short-term side effects? This is when it's given to more healthier people. What is your body's immune response? Are there signs that the vaccine is protective? Now, the third stage is what we all know about, because that's the most apparent one. That happens only if it has crossed through phase 1 and phase 2 successfully. In this, you have 1,000 or more volunteers. It's for a little bit longer time. And then you compare when somebody gets the vaccine and someone who doesn't, and what are their outcomes, whether it's side effects from the vaccine, whether it is an end result of, hey, did they get coronavirus? How severe was the coronavirus? Did anyone die? And then that data, once it is reached a certain stage in the study process, is collected, reviewed, authored, and then published to the regulatory authorities like FDA. And the FDA approves a vaccine only if it meets 2 criteria. One is it's safe and effective, and then the other thing is the benefits outweigh the risk. And now, even after stage 3 or phase 3, there's a post-release monitoring. And this is important because, you're going from a few hundred in phase 1 to a few more hundred in phase 2 to a few thousand in phase 3. Now you're talking about millions of people. And that's what is important to know. The post-vaccine release monitoring is consistent and continuous. So what does that mean? So about December 2022 vaccines, which we popularly know as Pfizer and Moderna, got emergency use authorization. And they got authorization based on the simple fact that data demonstrated that the known and potential benefits of the vaccine outweighed any known and potential harms of being infected with the coronavirus. So now what does that mean? Now, after it's been released and now we are in the phase 4 monitoring, we have to make sure that there are monitoring systems available to check for adverse events. And with this coronavirus vaccine, in addition to the existing safety monitoring system, which you see on the left-hand column, you have now a new expanded safety monitoring system available as well. Now, what is highlighted in purple is done by the CDC. What's highlighted in blue is by the FDA. So existing safety monitoring system, and most pediatricians are actually aware of it, but on the adult side, it's not that very common. It's VAERS, there is VSD, which is a vaccine safety data link, the CISA project. Then there is claim-based data from Medicare. You've got the BEST data, which is biologics effectiveness and safety systems, and then the Sentinel initiatives. Now, on the expanded safety side, so with coronavirus, they actually went a step ahead and said, you know what, we're going to go and do an additional monitoring layer, and that's called vSafe, which is vaccine safe. And then there's the NHSN, which is used to monitor hospital quality and patient safety. It's been tracking some vaccine data too. Now we are also expanding into other large insurer and payer databases as well as we go into the post-release monitoring. So what is vSafe? vSafe it's an immensely smart thing which the CDC has done, which is they put it as a smartphone-based tool that uses either text messaging or web surveys to provide personalized health check-ins after you receive the coronavirus. And based on that information, someone from CDC may actually call you and check in on you and get more information because it may be something of significance, or they will ask you to follow up with your PCP. What it also does, it will remind you to whether when you're due for your second dose vaccine, when you're due for it, it will remind you of it as well, that you got it, and then follow up again after that. It is extremely important that when we were administering the vaccine within the hospital, we made sure everyone who got the vaccine was registered and be safe. And that's an initiative that we think is very important, because the data that is collected is going to go into this master database. It's anonymized, but it goes into this master database, which gives us information about how safe is the vaccine, and secondarily, how efficacious is it. And that should be helpful in us in terms of getting more people involved and getting them vaccinated to show them that this product is actually safe. Now, one of the things that people always ask me, and I guess I go back a few slides, is that, Anuj, is this vaccine rushed? They did it in under a year. Other vaccines take about years to come through. Now, that is absolutely true. Other vaccines do take many, many years to come through, but this process was not rushed. The science is very solid. The mRNA technology is not a new technology. It has been used in oncology for some time now. What you also have to remember is there were a lot of bureaucratic hurdles in any sort of vaccine development. And those red tape was completely eliminated and fast-tracked for this process, for the vaccine development. The secondary portion of it is enrollment of populations, especially when you look at phase 3. With coronavirus, that was very easy, actually, to be very honest with you, because about 34,000 people were involved in each one of those studies. And that's pretty big numbers to get in a normal study. With coronavirus, they were able to enroll it in record time and actually move ahead with the study. So that in terms of the science, nothing was compromised. In terms of the technology, nothing was compromised. What was compromised is the time that it took for bureaucratic approval processes. And that is something that is actually going to be a push towards reducing red tape, probably for the future vaccine releases as well, or future drug releases. And we'll see how it goes along. So moving on. So will the vaccine make me feel sick? And, we hear this often, that I don't want the side effects of the vaccine. And I think Dr. Nigel and Dr. Nambiar actually pointed out in a very good manner that people forget very quickly the long syndrome. I keep telling the younger population, I'm not worried about you dying. I'm worried about you being that 10 to 20% of population that cannot exercise, that will be fatigued, will have chronic headaches, that wouldn't lose hair, will have neuropsychiatric symptoms, whether it's depression, bipolar disease. We don't want that. And so when you talk about this vaccine and you look at the side effects, most of it is localized side effects. About 70% had pain at the side. I got my vaccine. I had pain at the side of my arm. But guess what? A day later, I was fine. I had fatigue. A day later, I was fine. So those are very important things to remember, that even if you feel sick, it's not permanent. It is for a day, literally within 36 hours, you'll be out of it on the other side. And that's very, very critical, that this should never be a barrier to taking the vaccine. Moving on. So let's talk a little bit about state of vaccination in the USA. I kind of focused within the US Republic, because I feel like this is important, because, one thing was that masks became a political issue. Vaccines were trending to become a political issue, but thankfully it did not. So the President Biden has promised that he's going to administer 100 million vaccines by his 100th day in office. And on an average day, we are doing about 1.5 million vaccinations every day. And that's a pretty good number. So in terms of the doses delivered, we have had about just under 70 million doses that have been delivered, out of which 51 million have been administered. In a state like New Jersey, about 1.2 million have been delivered, and 900, just shy of a million, have already been administered, which is consistent with your national trends, which is about like 70% of the doses delivered have been administered. And I believe that we've secured another 200 million doses of the vaccine, which should be helpful in getting it out into the arms of everyone. So what are the COVID-19 vaccine rollout recommendations? This is a little bit of a busy slide, and I think it just behooves us to follow it for a quick minute. Now, the recommendation, this is from the CDC itself. The recommendations have been made with one goal in mind, which is to decrease death and serious disease as much as possible. How do we do it? We want to preserve the functioning of society, and we want to reduce the extra burden of COVID-19 is already having on people with already facing disparities. So who became 1A? Phase 1A became the healthcare frontline personnel and the residents of long-term facilities. And the reason for that was simple. On one hand, you need this core group of people to take care of other population when they get sick. And on the other hand, we have the group which is the most vulnerable, because during the midst of the pandemic, almost all the practicing clinicians saw this, that you had the first patient comes from a facility and boom, after that, it just becomes free for all. Like patients just keep coming in and in from the same facility. So it was very important that we took care of the patients and residents of the long-term care facilities first. As we expand into the 1B, and that's where most states are, and we'll go into the next slide of that, we go to frontline essential workers, and every state is doing it a little different. And within the state, some counties are doing it differently, and that becomes problematic. But everyone defines frontline essential workers differently. I believe it should be anyone who is involved in providing services to other people. But then again, I'm not the one making the determination. So what it means is firefighters, police officers, DPWs, corrections, agricultural workers, USPS workers, grocery store, transit workers, and those who even work in the educational sector, like teachers, support staff, and daycare workers. People who are over 75 and who are not residents of long-term care facilities should be offered in the phase 1B as well. Then you move on to 1C, which is people aged 65 and over, and those who are within 16 to 65 who have underlying medical conditions such as COPD, diabetes, hypertension. Jersey went a stage further and said, if you've ever smoked, you would be considered as a high risk, which I completely agree with. And then you have other essential workers who will work in the transportation, logistics, food service, housing, law, energy, media, public safety, and public health. So how do we go about it? This is our current timeline, the way it looks if we go at the current pace. This is the projection. It's again from the CDC. We are currently at about 11% or just about 40 million people vaccinated as of February 13th. If we go at the same 1.6 million doses or 1.5 million doses every day, we will reach 50% of the population by June 26th, 70% by September, and about 90% November 10th. And it's very important to remember that you have to reach between above a 70% threshold for herd immunity. Also, what my personal belief is that this will start to taper off as we go towards the 50 to 70 mark, because that would be your eager people who wanted to get the vaccine. Thereafter, you will see people who may be still vaccine hesitant or vaccine resistant or flat out anti-vaxxers who would not want to be vaccinated. And it's important that we get them to prevent some of the things that Dr. Nigel said about strains, mutated strains developing or not achieving herd immunity. So right now, this is a little bit of, again, a busy slide, and you can see it on the New York Times. There is a extremely good interactive screen on the NY Times website. And this is who is eligible for the vaccine based on each state. And what you can see is that there are certain states like, say, South Dakota or New Mexico, which still are at only 75 and above, or they're still in only phase 1A. Others have moved to 65 and above, while as others have even gone to 60 and above. Healthcare workers and residents of long-term care facilities across the country are eligible, and they have been getting it for weeks now. The federal government recently recommended 65 and older. New Jersey state actually is going down to phase 1C soon. And the states are right now creating and implementing their own plans. And sometimes their own counties deviate from those plans. That's why it's leading to a little bit of national patchwork of policies. And hopefully we will have some consistent messaging out of the White House and the CDC. And that will allow us for a much more seamless vaccine distribution and vaccine administration. With that, that's the end of my slide deck. Thank you so very much for allowing me this opportunity to come and present to you. I appreciate it very much.
Thank you, Dr. Mehta, for that much needed discussion about vaccine and its rollout. Now it's my pleasure and privilege to invite the next speaker, Mr. Joshua Prasad. Mr. Joshua Prasad received his master's degree in public health from Drexel University and completed a fellowship in health innovation and Harvard Medical School. Obtained his bachelor's in English and psychology from Rutgers University. Joshua Prasad is focused on equity through public health, innovation, and community. He has worked in health policy and management in senior roles at the US Department of Health and Human Services, also at Delaware Government and Public Services, running an integrated behavioral health center focused on rural Medicaid patients. He has developed and exited several tech startups, runs a collaborative focused on community health and power, and is the board chair of a national nonprofit focused on chronic disease prevention. He was named Drexel University 40 under 40 in 2018 and is currently an affiliate faculty member of the School of Public Health. Please help me welcome Mr. Joshua Prasad, who will speak about health disparities in COVID-19. He's incidentally joining us from Minnesota.
Hi, everyone. Thank you so much for that introduction. And thank you to all the other speakers for really informative talks about this terrible pandemic and the disease there and our vaccine rollout as well, too. I'm going to focus a little differently on the preventative side of COVID-19 and some of the equity concerns related to the disease. One thing I just want to mention, I am back at the U.S. Department of Health and Human Services. I'm the Director of Health Equity for the Office of Innovation at HHS now. But this is mostly my personal opinions here, and it doesn't reflect the actual federal government's opinion. But I think we're very much in line in a lot of the things that we're looking at here because it's all based on data and science. Just a few definitions to help level set for the topic that I want to talk about here as it relates to COVID-19, because I've found that a lot of people don't know some of these definitions. So just to clarify, the social determinants of health are the idea that there are social or economic or structural parts of our society that impact our health potentially more than our genetics and our physiology. A good way to think about this is, or a slogan that I've heard that helps explain this better, is that our zip code tells you more about your health than our genetic code. And it, largely in America, that tends to be true, especially when we think about how health is experienced by different people based on where they live, their race, their sexual orientation, and other key facets of their identity. These things lead to what we can call health disparities, the differences between populations and what we can call disadvantages in health largely because of these social determinants. And so our goal in this space is to achieve health equity, or really the highest level of health for everyone. Ideally, our goal is to get everyone the opportunity to start at the same place and get to the highest outcome that they personally see as important. And so keeping that in mind, thinking about COVID-19, one thing I'll add just related to these definitions is that oftentimes we talk about them from a chronic disease perspective. That's diabetes and obesity, smoking-related mortality, et cetera. And but that's where we see the most impact of social determinants in our communities. If you live in a poor neighborhood, you're more likely to have a certain diet based on your access to food, and that might lead to a higher incidence of obesity or diabetes. And so largely, while we can treat the conditions you have, treating the neighborhood and trying to improve the structures around you and the food access in your community can have a big impact as well. So then when we think about COVID-19, which is a respiratory communicable disease, it might seem a little antithetical to think of it that way. But so we might wonder also, why are certain populations seeing higher incidences of this condition, and it tends to be along racial and ethnic lines in America. And it's not because there's any sort of genetic component that means that a certain race or ethnicity has it, but it's largely a social social construct or social underlying reason as to why. And so I want to help us think about prevention and how we can prevent the spread of the disease from social parameters outside of the healthcare system, but definitely related to it. And so just a quick 101 on public health prevention. You can think about primary, secondary, and tertiary prevention as the technical terms, but if our goal is to prevent any disease or death from any condition, there's things that can be more and more effective than other things to actually prevent those things from happening. And so with a respiratory communicable disease, our best option is to stay at home, isolate, quarantine, et cetera, and so that the disease just can't spread. That's our ultimate goal. Obviously, we live in a real world, and there's a lot of complicated reasons as to why we can't do that. And so we have a bunch of other preventative health solutions to hopefully to aid in preventing the spread of the disease as well too. Right now, we've heard a lot of great presentations on vaccination, social distancing, wearing masks. We know that these things will help prevent the spread. That does mean that we have the disease out in the community, and so we're doing what we can to prevent it from spreading further. Similarly, testing, contact tracing, these are public health tools to track and see where we are, but again, the disease is already in the community as well too. And then the least effective way, but still very necessary way to prevent disease and death is treatment for the condition. And so our goal is to hopefully never get to the point of treatment. Let's prevent the spread of the disease at home or in communities. That way we can alleviate the alleviate the burden on our healthcare providers and make it as easy as possible and squash this pandemic, flatten the curve, if you will. And so, unfortunately, up until now, we're still not doing a good job of doing that. COVID is now the top cause of death in the United States, and it's disproportionately impacting certain populations, like I mentioned before, and many of the other speakers mentioned before too. When we say disproportionately, that means if you see the bottom green bars at the bottom, that represents the actual population by race in the United States. And if the bars don't line up with the prevalence of the disease in certain races, that means it's disproportionate. So there's 60% of the population is white, and only 12% of them are getting and contracting the disease. There are some social reasons as to why it's spreading less in that population compared to others. We're in the Asian bracket, and we're also doing very well in terms of the spread, but we're seeing very disproportionate spread of the disease in Native Americans and Alaska Natives, other indigenous populations. There are a very small percentage of this population overall, the United States, and yet make up a major part of deaths in the disease. As are Black and Latino populations as well too. They're greater than the indigenous populations, yet but also have a pretty high proportion of death in their groups. And so, why then are these groups more likely to get and die from COVID-19 at higher rates? And so, there's definitely a lot of different reasons here. We're still learning a lot about this virus as it spreads, and so this is not comprehensive. I think there's many other factors, but based on the social determinants of health and other areas that we could focus on, I'll just outline a few. The first being less of an ability to isolate and quarantine. That number one primary prevention thing that we talked about before was being able to stay home. Like Dr. Mehta mentioned before, we have an interesting definition for essential workers, frontline workers, et cetera. I've seen different numbers on this. Something like 20% of adults are essential workers. I've seen it even higher, like 30 to 40% as well too, which is far too high of a number of our population that we deemed essential and thus keep in the workforce. And it's and those areas that they work in are grocery stores, public transit, et cetera, healthcare as well too. And unfortunately, what that means is that they can't stay home. A lot of people, myself included, are remote workers and can stay home as much as possible, prevent ourselves from getting the virus. But people who are essential workers have to go in to their stores or other places of work and do their job in order to keep making money. And so, unfortunately, also we have a larger Black, Indigenous people of color. We can call that BIPOC. BIPOC individuals are overrepresented in that population. They're also more likely to live near or at the poverty line, have no health insurance, and more likely to be caregivers, people taking care of people who are over 65. And so not only can they not stay home as much as possible, they also, like financially, are less able to quit their jobs and just stay home, because they also still have to take care of their family members. They have to eat food. They have to pay their rent, as we all do. And so it's a major consideration there with regard to the spread of this disease, and in this group of people. By being saddled with more of this work, they can't stay home and isolate as much as many of us can. Two, and this was definitely highlighted before, are chronic comorbidities, which are exacerbating COVID-19. I'm not a doctor or medical expert, so I defer to the other folks on this call, but we know that there's a relationship between certain chronic comorbidities, chronic diseases that cause a worse expression of COVID-19, and that's leading to higher rates of disability or death in those populations. And so we can consider, especially from the chronic disease perspective, the social implications of these, like I mentioned before. If you have less access to food, healthy food, then you are more likely to have diabetes or hypertension or obesity, and that is now rearing itself through COVID, because it's causing worse COVID as well too. And so those are just some of the reasons. Like I said, there are many, but from the social perspective, ones that I wanted to highlight. And so what can we do about it then? We can talk about it, and the physicians on the phone talked about all the medical options that we have, but we have public health, policy, and social solutions to this as well too. And the first is enable primary prevention by incentivizing more closures as much as we can, workers to stay home, encouraging people to wear masks and social distance as much as possible. And unfortunately, as the death rate has become the highest cause of death in the country, we've also seen more reopenings across the country, making this less likely. While and as Dr. Mehta mentioned in his slides before, we're not quite at the point of herd immunity or vaccination yet, and so it's still a little preliminary to start reopening. And so the more that we can do to encourage staying home and not going out as much as possible will help encourage that. So we could potentially reconsider the list of essential workers, lower that number of people. One thing I'll note is that 12 million people are unemployed because of the pandemic as of December 2020. That's a lot. Disproportionately represented by BIPOC individuals and women. And so we're not only are those people willing to go back to work to feed their families and themselves, they're unable to make their ends meet currently too, which is just exacerbating problems for them further. And the other thing I'll mention on this slide as we're getting close on time here is increasing mask utilization. 71 in a survey earlier this year, at the end of last year, 71% of people said that they would wear masks, which is incredibly low. We know that there's been big conversations about mask wearing. We need that to be 95% or higher. That's considered universal mask wearing. And so we have to do a better job of encouraging and incentivizing people to wear masks as much as possible. The next thing I'll talk about is vaccines real quick. Again, from a distribution perspective or a population health perspective, is BIPOC individuals, particularly Black populations, are not getting the vaccine as high rates as we have hoped. There are multiple reasons for this. There's historical hesitancy due to like mistrust, essentially, by Black populations and other, and I would say in indigenous populations as well too, of the medical establishment and the government. And so addressing those historical hesitancies would be really key. You can see on this scatter plot graph on the left, that we're way behind in target populations. While our numbers might be getting good or better in the broader population, we're missing the mark on the populations that need it most. And what I'll also mention is, if you look at this map of DC, for example, our distribution strategies for the vaccine are not the most effective that they could be. For example, on this red map here shows COVID-19 incidents in the wards in DC in 2020, where it's mostly, we're seeing more cases in the southeast of DC, the bottom right of that map. And if you look at the vaccine bookings from January 2021, it's in the north west of DC. That's where they're getting more of it. And by no coincidence, potentially, most of the Black people in DC live in the south east. And so we need to rethink our strategies on how we're actually getting the vaccine out to people. I think this has already started, and like happily that this map is potentially out of date already. I've heard of some new strategies that they're trying to tackle this and get this herd immunity up through vaccines. And then finally, ensuring equitability in treatment is a key thing. Because of, I mentioned before, 12 million people are out of jobs. Nearly half of those people lost their insurance. While COVID is covered, nothing else is. So if you got COVID and then you have other problems as a result of it, and you don't have health insurance, that becomes a problem. So making sure that we can expand coverage, have some sort of universal coverage, at least during the pandemic, if not longer, would be really critical. And this disproportionately affects minority populations, people of color, et cetera. An interesting point that came out of Boston last year when the pandemic hit was that there was a growing, because this was pocketing in minority populations, there was a need for interpreters to actually talk about the symptoms and what people were experiencing with patients. And so there was a need in healthcare facilities for more interpreters and translators and having language to explain the problems of COVID to patients in a more effective way. And then more generally, this is a population health level consideration of hospital beds, but the way our closures are working are not necessarily related to our hospital bed capacity. I'm sure many of our physicians could talk about the ebbs and flows of whether their hospitals have been slammed or empty over the past year. I'm going to assume many of them were slammed at really key points. And in many cases, counties stayed open despite that. And so potentially considering how to relate our closures in counties to hospital beds more effectively, and considering what would be extreme stress on hospitals needs to be a major factor. Our healthcare workers who are working on the front lines of this pandemic need to be considered better, and we can do that if we start paying more attention to these types of things. And so I'll wrap it up by saying there's three things we can try and do: avoid large gatherings, stay home as much as you can when you're going out. Recently, I think I just saw that you can wear 2 masks, and there's increased effectiveness as well too. And encourage vaccination. It is proven safe, as we learned today. And when it's your time to get your vaccine as well too, please do get it as well. And if you have any other questions, my email and a counselor listed here. So thank you so much for the opportunity. I'll hand it back to the moderators.
Okay. To me. All right. So now we just are Dr. Kripa Nambiar and myself will be moderating the Q&A session. And I want to thank all the panelists for staying on. And if we could open the forum for questions. So if there's any questions, we ask the audience to ask it through the chat format or through visual. And I believe the media people will guide us with that. Sudhir? Yes.
Dr. Mamet,
Yes.
while we wait for questions, can I just point out one thing that Joshua brought up that I think was relevant? East Orange General Hospital serves predominantly urban Black community. And one of the things we realized early on is that there was a significantly high proportion of vaccine hesitancy and the feeling that they are
But
being
that was the question we had for you.
Oh, okay. That's
You
perfect.
answered. We had some questions ahead of time, and that was one of the questions in an urban setting. Yes.
Right. So we actually did a
Start with the
lot.
question. Yeah.
We actually did a lot of education sessions within our staff, and myself included, and some of our nursing leaders actually went out and spoke to our staff members and got a significant portion of them converted over to getting vaccinated. This was in the initial phase when we had just about 30% vaccination within the hospital. We are now at about 60%. But thereafter, we actually encouraged them to get their friends and family members vaccinated. And we've reached a certain stage now where out of the 2,000 doses or so that we gave, 1,900 doses we gave, about 50%, just about 50%, sorry, went to Black community. And the second highest group was Caucasian, the third was Asian, and then the fourth was Hispanic. So we were able to actually switch it out by leveraging our local levers and our local population, like the staff that worked in the local region, to get more engagement, because people tend to listen less to us, but more to their spouses, their friends, the people they interact with at the barbershop and stuff like that.
Right, absolutely. Yes, thank you. So we have a question from one of our women physicians. I'm sorry, Shija, do you want to ask the question for Dr. Nisha? For Dr. Nisha Nigel?
Sure. So first of all, thank you, everyone. Very informative session, right? So my question was, should people who have been affected with COVID get vaccinated just so that they are prevented from other mutations and variants of COVID-19?
Yes, also because, so especially if the infection is very mild, the duration of antibody-mediated protection might not be long-lasting, and it may not be strong enough to prevent a reinfection. So that's one point. And then the second point is like protecting against variants or next time getting severe disease from another variant. So and also we do know that vaccine-induced immunity is stronger than what we get through a natural infection. So general recommendation from all sources is that everyone should get vaccinated.
Yeah, we have several questions in the chat line. If you could, yes, go ahead.
Nandi, I have a question. One of my friend, she got the first vaccine, and then after that, they informed, they ran out of vaccines, or they're running short of vaccines. So what is the scenario in that case? You took the first shot and you are not able to get the second vaccine. Where will it go?
Dr. Mehta, can you answer that in vaccine distribution?
Doc, can you please restate your question? I'm sorry, I couldn't listen. I had
My question is that you get the first dose of the vaccine, and before you get the second one, there is a shortage and you are not able to get it on the exact date, like 28 days or whatever. What is the scenario?
So a couple of things. When we had a little transition in the president, and that actually changed some of this vaccine strategy. With the first presidency, we did have, and so far actually, if you got a first dose, the hospital or the facility that gave you the first dose is going to get the second dose. So your second dose is guaranteed. Now, when can you take it? You can get it plus or minus 3 days for the Moderna vaccines. We've seen people get up to plus or minus a week. We try not to do that. We try to keep it within the 3-day window. Now, if you had COVID in between those two, then we defer you out, like Dr. Nigel mentioned a little bit earlier. And again, depends on the severity. So we try to get you in within the week, if within the 7-day plus or minus period, if you got the Pfizer vaccine. And you will have the vaccine if you got the first dose.
Question about the disease. If people who are infected, if it's like a mild to moderate infection, they are allowed to get the vaccine after the acute phase is over, or 2 weeks after the onset of symptom. But in people who are hospitalized and who have also received convalescent plasma or monoclonal antibody treatment, they are advised to wait for 90 days before they get vaccinated.
So just
Doctor,
a-
this is Philip Thomas. I'm the chairman of World Malayalee Council. I have a question for you. What about the senior citizen? How are we going to take care of them after getting the injection or after getting the vaccination? How are we as a community? Are we supposed to do anything? Are we supposed to take any leadership as a community? Are we supposed to do anything, or the government is going to take care of it?
So right now we've got. Sorry, I'll just try and take that first stab at it.
Yeah,
I'm
that's
sorry about
fine,
that.
Mechanica. Go right ahead.
So right now the government is kind of directing who gets the vaccines. You do have a little bit of a trickle down happening. So that, like, the government decided we're going to give it to pharmacies, we're going to give it to hospitals, we're going to give it to certain FQHCs and clinics, depending upon their ability to store the vaccine. Now, those hospitals may have voluntary outreach programs. The community, the counties may have outreach programs that would decide who will get the vaccinations as a secondary tier. And that is somewhere where the community can come in and be like, hey, we've got enough volunteers who can administer it. We have this method of tracking it. We have this method of storing the vaccine. This is how our back-end paperwork would work out. Can we get some portions of it, and we will do the work of administering the vaccine. It's very tricky right now. From my perspective, trying to get it out into the community has been very tricky because of an inconsistent supply, which we are hoping that it'll get more stabilized as time goes by. But I hope so. Right now, it's more the hospitals and the government trying to do it. But there are a lot of people who are doing these outreach and social kind of like a camp, so as to say a vaccine camp. But this is not something that you can do as once and done. This is 2 doses, and that's what makes it a little tricky.
There's a lot of questions in the chat. Someone can ask that.
I'm not able to find the chat questions.
Yeah, I will ask Andy. The
okay,
next
right.
question is like, can mosquitoes or ticks spread the virus that causes COVID?
No, Dr. Mammon, do you want to take that?
We don't know much about. I know pets do carry coronavirus. They have, that's when they get vaccinated for certain kind, but not COVID-19. I don't know much about ticks. Those are informations I don't know unless the panelists know something different about that. We are not familiar with tick-borne illnesses causing COVID-19. That has not been reported as far as I know. But in terms of pets do carry certain corona, but I am not familiar with the vet standpoint for COVID-19 transmission among pets to humans. Of course, we know about the other form of transmission that was bats and so forth, but dogs and cats and so forth, I don't know at this point, other than what was mentioned in the Wuhan study where the those markets were the sources, but domestic pets, I don't think so at this point. Unless somebody else can give us a further input, Dr. Nisha.
No, I don't think I know more than.
The next question is that someone is asking, can I take steroid while waiting for my second dose? I have a COPD and my inhaler contains steroid.
Yeah, I can take that question. Yeah, it's not a contraindication. And if anything, steroids, there was a recent trial published last week saying that inhaled steroids are protective against hospitalization and severe disease and COVID. So you're getting double protection, I think.
There is another question. What will be the frequency of taking this vaccine? Like, will it be a yearly thing?
Forward? There is talk about a booster dose, and then the way the pandemic is going to end, we are going to see that the virus is becoming endemic, like the influenza after the Spanish flu. So we might be taking booster doses. And then one of my last slides did mention that we're looking at getting a single vaccine which can cover all the potential variants, and that's also in the pipeline. So
if you take that, can we avoid the flu vaccine?
No, it's a
different variant. Okay.
Yeah.
And another one, my question is like, is there any testing of the vaccine for kids going on? Will they get it? The kids below 16?
Yes, this currently ongoing.
They are being enrolled in the clinical trials, and hopefully by summer or fall, we will be vaccinating kids. Because interestingly, from data coming out of Israel, there is some concern that more kids are getting affected with the new variant, especially the B117. So we are starting to see more severe disease in kids. We don't know. So
Right. Yeah. Actually, just in the last 2 weeks, we were seeing increased cases of MIS-C, and those kids were all, antibody positive, but we can't test to see if they are having the mutant or the variant strains as of yet. I mean, that's not something we routinely do in a hospital setting. But anyway, yes, that's correct.
We have one more question. Are these mutated variants or strain as bad as the present virus in regards to incubation period and the severity?
So the infectivity is definitely higher. And there were some reports from UK saying that they might lead to severe outcomes. But we're waiting for the American data as well. I mean, it's conflicting as of now.
Yeah.
Yeah.
We have like Dr. Isha, at least 40 states, right? How's it B17?
Yeah. Okay. Yeah.
Then somebody is asking, what happens if I miss the second dose due to my fault? Like, do we have to take the first dose again?
No, they probably just give it to you, when you come back up. I mean, it's not recommended that you miss it, but the latest you go is like 6 weeks. So we don't know any of that information at this point.
Right. And that's the recommendation at this point in time. Do not miss it. Plus or minus 3 days, if possible, plus or minus 7 days. And then if not, then within the next 2 weeks, we'll get you. It's important. Like you saw Dr. Nigel's graph, the second dose is where it really takes off. And that's why it's important.
Okay.
Also, because in the trials, they strictly followed the time interval. So whatever efficacy data we see is predicted based on the trial dosing. So it's better that we stick to the trial regimen.
Okay.
But interestingly, for people who have had a prior COVID infection, even one dose, there's speculation that even one dose will give them a good amount of protection. So there's no strong recommendation for that yet, but that is being considered as well. And also just today, just actually like half an hour ago, there was a new update coming out for Moderna vaccine saying that even half the dose is sufficient to give good immune response, so that more people can get vaccinated. So all sorts of new things are happening. And
okay, someone is asking if they're taking methotrexate, for arthritis, is it safe to take the vaccine? Is it an issue?
Dr. Nisha can answer that.
Actually, no, there's no contraindication. They can continue. And I'll share the link. Actually, my husband is a rheumatologist, and he's also the vice president of Canadian Rheumatology Association. He gave a very nice talk for rheumatology patients. I'll share the link here. And again, methotrexate is not a contraindication.
I would, however, just put that disclaimer out there that in all these particular cases, please do talk to your physicians because what we are giving is general advice. In everyone's individual case would be very specific, and it's always good practice to ask a doctor. If you're able to get the vaccine, call the doctor. They'll be more than happy to discuss out whether you're eligible or whether you have any contraindications or whether you should get it or not.
Yeah.
So
that's exactly the reason I didn't go into the specifics in my slides too, right? So it's
yeah, they really should check with their physician. Yes.
Yeah. But if you look at the risk-benefit ratio, the general advice from all the specialists will be like.
Thank you. That's a good suggestion.
Yes. Someone is asking, do we have to wear the mask even after getting immunized?
Yes.
And for how long?
Maybe until we get the herd immunity, probably. It could be at least 1 year or even more.
Mask is here to stay for a while. Okay, there's a question coming on the chat regarding pregnant women. I know Dr. Nisha Nigel covered the pregnant women that she said it was okay, but is there any particular stage in pregnancy that would be of concern in getting the vaccine, meaning first trimester, second trimester, third trimester? Does it make a difference or not?
No, this data has been dissected in many ways. So in general, what they say is the final conclusion is that you go by the risk benefit ratio. If you are a healthcare worker or frontline worker, and if you are in an area where there is tremendous community spread, your risk of getting the disease is higher. So it's better to get vaccinated. And even in the Pfizer experiment, they have done studies in mice, and they found no problems in the fetus or in the offspring, and also during the second or third stage of vaccination. Of course, and I showed the data on those 10,000 women, and again, no real concerns. The pregnant women were not found to have more serious side effects also. Let's say they had more fever or more body pain. None of this has been reported so far. So again, it's like as Dr. Gupta just said, it's a risk benefit thing, an individual decision.
Okay. Now,
this question no maybe risk of miscarriage.
I'm sorry.
There was a question on the elderly. This is open to anybody on the panel. There was this article that came out of, I believe, Sweden or Norway, where there were elderly who got the vaccine and succumbed right after the vaccine. Can you shed some light pertaining to that? Was that something to do with the elderly's immunity, or do you think there was a bad batch, or what was the outcome, you think? Or it could be speculative.
Yeah, I think the data that came out of Norway, but when compared to the mortality in that age group, in the very frail elderly people, it was something similar to their background death rate. But then again, in elderly, I mean, there was also a question of why some of these people were even vaccinated, right? Like Dr. Mammon just said. So that was the concern. Again, in a nursing home scenario, we cannot exclude one or two people just because they are very frail, because you are looking at preventing an outbreak in that particular setting. So each setting is different. So it's very, very difficult to make a generalized statement based on such anecdotal reports. But in general, if you look at millions of, I think so far, even in the US, millions of nursing home people, even in Canada, have been vaccinated, and their risk of dying from the COVID infection is much, much higher than getting a side effect or a mortality effect from the vaccine itself. So again, it's a risk-benefit profile, right?
Now, maybe Dr. Nigel, you can answer this question. There's a question from the chat. Can Moderna and Pfizer vaccine be interchangeable?
No, in general, this comes up a lot in vaccine discussion. In general, it's not recommended. Yeah, of course, the Moderna vaccine is stronger. The mRNA component in the Moderna vaccine is stronger than Pfizer, but the efficacy rates is the same. And again, only because we don't have data.
Yeah,
exactly, right.
And from an administrative point of view, we don't allow you to get the vaccine changed out.
I think it's mainly because of now that this vaccine inavailability, people are kind of like saying, okay, they took the Pfizer, can they go and take the second dose? Can they take the Moderna?
Let me just reiterate it. If you got the first dose, you're guaranteed a second dose. At least in the USA, we can tell you that. You got the first dose, you're guaranteed the second dose. There should be no doubt about it. You will get it. It may be delayed by a few days, but you will get it. So no need to scramble for the second dose. The first dose, yes, you will have to scramble for that right now.
Yeah, I have a follow-up question on the same question. We know that the technology used to develop Pfizer and Moderna are single stranded, that is RNA-based one. And for the AstraZeneca, they use the method of double-stranded the DNA type, right? So what is the major difference between these two, and what is your recommendation on any type of group of people or any particular age group, which one they can administer? That is one more question. And I have another question also, which was given by somebody, which is most of the times patients admitted to the intensive care unit are due to respiratory failure. Is there any research conducted that suggests COVID-19 increases risk of ICU acquired bloodstream infections?
Okay. Well, the longer you stay in the ICU, the greater the chance of getting the infection. So they are inundated with a lot of lines, and technology makes them stay alive, but there's a cost associated with that, right? Foreign bodies are in these patients for a long period of time. The intubation is there, lines are there. These are all nituses for infection. Yes, there's no guarantee that you won't have a eclampsia, as we call it, a central line infection, or a urinary tract infection, or pneumonia, which we call health-associated pneumonia or vent-associated VAP. These are all the risks that occurs when you stay in an ICU for a very long time. And that's one of the things we tell with patients, that there's no guarantee you're going to be out in a week. Sometimes it may be 2 weeks, maybe a month. It all varies on the individual patient. But in our field of infectious diseases, and Dr. Mehta could probably account to that as well in our ICU at Eastar in general. I mean, they were staying there for weeks. And that's one of the issues, and that's why it's important that we get everybody vaccinated to avoid some of these complications that can occur with COVID-19. So there's a good example and a good question pertaining to that. Yes.
Thank you, Dr. Prasad. Can someone answer my first question about the two different methods that they used to develop these vaccines?
Yeah, I'll leave that to Nigel. Dr.
Yeah.
Nigel.
So yeah, of course, the technology is different, but fortunately, the clinical efficacy has been somewhat similar in preventing severe disease and death. And there are no strong data to support that, one vaccine is effective in certain subgroup over others. Let's say Oxford vaccine is better in seniors versus. There's nothing like that. So in general, I think we keep repeating this message. Take the first vaccine that's offered to you. They are all good, unless you have a documented allergic reaction to a particular component of the vaccine. But otherwise, it's whatever is being offered to you.
Thank you, Dr. Nigel.
I have a question. There's a question coming for Joshua Prasad. Joshua? Is he on?
Yeah, he's there.
Huh?
He's there.
Hi. Yeah, I'm here.
Yeah. They're asking us, do you think the vaccine could be improved in the areas in the urban setting by having more clinics, which we're not sure what the statistics are? Is it because they're not having enough clinics is the reason why they're not coming forward to get the vaccines, or is it just the fear component with the vaccine? I know Dr. Mehta touched upon that the fear component is there, but if they're not getting enough access to the vaccine in the community, how do you suppose we can improve that? Getting funding, for example, from the government?
Well, and so I think Dr. Mehta hit it on the head before. It really stems to trust. I don't even know if fear is the right word to use. I mean, I think a lot of people are afraid, but there's also a level of mistrust and misunderstanding of what's happening with the vaccine, and who's to benefit from getting it. I was reading earlier today too that some people actually believe within the Black community that they believe that they are being targeted in particular because we're consistently messaging that Black people have it higher, thus they need to get vaccinated, and thus only Black people need to get it. And I think that is bad messaging as well too. So we need to start rethinking about how we say these things and thinking about why people aren't getting it and addressing those root causes. Lack of clinics or places to get the vaccine, I don't think are necessarily the problem. I think like the physical access doesn't even have to be in a hospital. In fact, it might be more effective, like Dr. Mehta said before, barbershops or other community places where people feel comfortable to get it. If you can stand up a vaccine clinic or operation there, here in Minnesota at the reservation that I'm working at, an indigenous reservation that I'm visiting, they're doing it at a local school, and they just took the gym and are doing it there and keeping people spaced out. And so potentially community-based locations are better. But ultimately, I think from the vaccine hesitancy perspective, related to what I was talking about, it's largely based on trust. And so how can we work with leaders in the specific communities that they're not, that are not getting vaccinated? How can we work with them to help get the information to the people who don't have it accurately and help convince them if they can be convinced? I don't think we should be forcing anyone to do it either. it has to be a voluntary action to do it, because it will just will feel the ramifications of forced vaccination longer term as well too. So it's about building trust, encouraging people to trust the science and from the leaders that they trust directly.
Okay, thank you so much, Joshua. Is there any other questions? We have a survey. We're getting close to the Q&A session component of it. We just want to see, make sure that you're able to answer the survey. And does somebody have that survey that they can put it up on the chat, please?
It's
Yeah,
already.
I did that just now. Yeah.
You did. Thank you so much.
Also,
Yeah.
I have the privilege of asking the last question.
Yes, please go right ahead.
Glad to attend this highly informative seminar. Thanks to all the panelists for this effort. Also, I appreciate the All Women Province leadership for bringing this topic. My question: studies have suggested anticoagulation prior to hospitalization is associated with better prognosis in patients with COVID-19. So what are your thoughts on that? Anyone can answer it.
It's not routinely recommended, but I believe I'll defer to the internists in the group.
Yes.
At least in children, we don't do it, but in maybe in adults, we don't prophylactically give steroids. Or I'm sorry, anticoagulants.
Dr. Elizabeth, can I ask you a question before you close, PC Matthew?
Okay, go ahead. But can
Can
I
I
have
ask-
Dr. Nigel answer that question, please?
No, I don't think that concept is mainstream, especially because of the bleeding risk associated with anticoagulation, right? So,
yeah, we don't usually recommend that. Yeah,
because even in hospitalized patients, the risk of bleeding is pretty high, with the anticoagulant use. So it's a double-edged sword.
okay, go ahead, Doctor. I'm sorry, Mr. PC Matthew.
Yeah, the Johnson & Johnson, they are also having a vaccine, I heard. That's only one-time vaccination, I heard. So what is the difference between one time and 2 times vaccinating?
I think that Dr. Nigel already mentioned that the vaccine efficacy was around 65%. Is that correct?
No, the Johnson & Johnson vaccine is somewhat similar to the Oxford vaccine. It's a single-dose vaccine. It has a human vector. The other one is adenovirus vector. And the efficacy is actually pretty good, very similar to the mRNA vaccine. And also the temperature regulations are very relaxed. You don't need a -70 freezer with the J&J vaccine. And their Ebola vaccine was recently approved by the FDA. So that technology also looks very promising, and it's a major breakthrough, especially because it's single dose in this case. And again, because they were a little late in the game, the trials were done in nearly 40,000 people. And also they have looked at efficacy in different variants, including the UK variant and South Africa variant, and it looks good. So already good efficacy there.
When you say good, would you say
That was
over
65? Yeah, 65 for the South African.
65% is what I understand it as. Yes.
Is it available in US now or?
Not yet.
Yet.
No. Thank you.
And maybe
Yes,
there's
sir, good.
greater adherence because there's only a single vaccine to be administered. So it's probably going to be, you see more people kind of like adhering to the vaccine protocol.
Right.
Yeah, I appreciate all of your time and a very educative and knowledgeable session.
Thank you.
Keep your good work.
Yes.
So, if there's any other questions, either Kripa, Dr. Kripa, or not Malini, can you see any questions on the chat that's remaining?
No, I think we've pretty much answered all.
Okay, so we can go to the next portion of it. I will now send it back to, I guess I'll send it back to Malini.
Yeah, thank you, Andy. Yeah, the next one, the task is to felicitate all the panelists who spent so much time in giving us all this information through the slides and your valuable time. Thank you so much, everyone. We are all very much educated right now regarding the COVID symptoms, the vaccines, its pros and cons. So I hope everybody will be ready to take the vaccine without any hesitation as of now. So thank you so much. So my duty here is to felicitate Dr. Nisha Nigel with a plaque from New Jersey All Women Province for being a part of this health forum. And thank you so much, Dr. Nisha. So I'll be reading out the contents from the plaque right now. World Malayalee Council Seminar on COVID-19 Impact in Adults, Children, Vaccine and Health Disparities, conducted on February 14th, 2021. With our deepest appreciation, we present to panelist Dr. Nisha Nigel for your dedication and service to the World Malayalee Council and to the global Indian community. WMC, New Jersey, All Women Province. Thank you so much, Dr. Nisha. Moving on to Priya. Priya Subramaniam will be giving the plaque to the next panelist in here. Priya, are you there?
Yeah, I'm here. So my duty here today is to facilitate Dr. Anuj Mehta, World Malayalee Council, Seminar on COVID-19 Impact in Adults and Children, Vaccines and Health Disparities, conducted on February 14, 2021. With our deepest appreciation, we present to panelists Dr. Anuj Mehta, MD, MBA, for your dedication and service to the World Malayalee Council and to the global Indian community. WMC NJ, All Women's Province. Thank you so much, Doctor.
Thank you. Thank you very much.
Next, moving to Tumbi to give the plaque to the next panelist.
Hi. I'd like to take this opportunity to honor Mr. Joshua Prasad, a World Malayalee Council Seminar on COVID-19 Impact in Adults and Children, Vaccines and Health Disparities, conducted on February 14, 2021. With our deepest appreciation, we present to panelist Mr. Joshua Prasad for your dedication and service to the World Malayalee Council and to the global Indian community. Thank you.
You're muted, Josh.
Oh, thank you. Thank you, everyone.
Thanks. Okay, now I would like to invite Dr. George Jacob, one of the founders of WMC, is handing over plaque to Dr. Elizabeth Mammon, one of our panelists for today, and she is none other than the WMC New Jersey All Women's Province chairperson. Dr. George Jacob.
Hello, hello, can you hear me?
Yes.
Yeah.
Yes. Good evening to everyone. Ellavarkum namaskaram. First of all, let me take this opportunity to congratulate all the leaders of the World Malayalee Council, New Jersey, All Women's Province. And I don't want to say many things, because time is too late. Thanks for your nice words. And it was well organized and very informative messages we got it. We have to do this time to time for our community, this kind of informative presentations. Only this time, only 60 or 65 people attended this program. So we have to give more advertisement, and we have to do this kind of information to our community. And I take this opportunity to World Malayalee Council Seminar on COVID-19 Impact in Adults and Children, Vaccines and Health Disparities, conducted on February 14, 2021. With our deepest appreciation, we present to our beloved Dr. Elizabeth Mammon Prasad for your dedication and service to the World Malayalee Council and to the global Indian community. On behalf of Chairman Philip Thomas, President Sudhir Nambiar, General Secretary Pindo Kannampalli, Treasurer Cecil Cherian. Thank you so much. And I do really appreciate Dr. Mammon's work for this community. Thank you.
Thank you, Dr. Jacob. Thank you.
Thank you, Dr. Jacob. Next, it's my pleasure to welcome WMC Global President Gopala Pillai. Handing over the flag to Dr. Kripa Nambiar.
Thank you. Respected guests, panelists, World Malayali Council Global Regional Provincial Leaders, എല്ലാവർക്കും നമസ്കാരം. Happy Valentine's Day to begin with. And also, I wanted to congratulate the New Jersey All-Women's Province for doing a wonderful, wonderful seminar on COVID-19 and its impacts. Congratulations. I also like to congratulate the America regional team for organizing this and supporting New Jersey Province. We are all proud of New Jersey Province, All-Women's Province. We had initial glitches when we presented to global committee about the all-woman province in America. America being the founding country where World Malayali Council started, and we feel proud that America again did another good thing, starting an all-women's province in America. Thank you very much. My responsibility is to present a small memento to honor Dr. Kripa Nambiar, MD, who is a panelist. Let me read. World Malayali Council Seminar on COVID-19 Impact in Adult and Children, Vaccines and Health Disparities, conducted on February 14, 2021. With our deepest appreciation, we present to panelist Dr. Kripa Nambiar, MD, for your dedication and service to the World Malayali Council and to the global Indian community. World Malayali Council, America region, given by Chairman Philip Thomas, President Sudhir Nambiar, General Secretary Pindo Kanamballi, Treasurer Cecil Charia, and from all of us, thank you.
Thank you. Thank you so much. Much appreciated.
Thank you. I just want to add, if I may, just please fill out the survey that was put up on chat, just a reminder. Sudhir, is that up already?
Yeah, it's out there. Yeah.
Okay. Dr. Nisha was just asking one more time if we could just let them know to please fill that out. Thank you so much.
Thank you, Mr. Gopal Pillai. The floor is open right now. If anyone wants to talk about today's session, please come forward and feel free to talk.
I just want to take a moment and thank everyone for inviting me. I really, really appreciate it. And thank you, Dr. Mamin Prasad. I work very closely with her, and it's always a pleasure. Thank you.
Dr. Mehta. It was really a pleasure having you.
All of you, please complete the survey form written there in the chat. Please take it as a help you are doing to the community. So please fill out the form. Thanks.
I just want to also thank all the panelists, Dr. Nisha Nigel, Dr. Kripa Nambiar, Dr. Mehta, and Joshua Prasad for, it was a lot of work, and, and in the Zoom capacity, it was really, really a lot of work. And I really, really appreciate their time, especially they volunteered all that time in their presentations. And I really appreciate that. And thank you to the whole group. I know we're getting towards the end and we're going towards the vote of thanks, but I just want to say just a minute to say thank you to the whole America region and all the people who came on board to join in with us. There are many family members that I see on our chat, and I'm really happy that they were able to join and ask all informative questions. Once again, thank you from me, the chair, I guess, of the WMC New Jersey Province. Thank you very much. I'll defer to Priya now.
All right. So hi everyone. It gives me immense pleasure to deliver the vote of thanks to this event to all dignitaries assembled here. On behalf of All Malayali Council New Jersey, All Women's Province, I would like to wholeheartedly thank our panelists, Dr. Anuj Mehta, Dr. Nisha Nigel, Dr. Elizabeth Mamin Prasad, Dr. Kripa Nambiar, and Mr. Joshua P. Prasad for their time and effort in sharing valuable information on various aspects of COVID. I would also like to thank All America Region, Province Chair, President, Forum Chair, and EC, Philip Merritt, A1 TV, and last but not the least, our beloved audience for making this event a success. Once again, thanks everyone for your presence here. Happy Valentine's Day to everyone. Thank you.
Thank you.
Thank you, everybody. Bye.
Bye. Thanks.
Thank you all. Good night.
Thank you all.
Good night.